One-step strategy. 75 GM-OGTT is performed after an overnight fast. Blood samples are collected at fasting for 1 hour and 2 hours. GDM is diagnosed if fasting glucose meet or exceed 92 mg per dl, 5.1 mol/L. 1 hour serum glucose of 180 mg per dl, 10.0 mol/L, or 2 hour serum glucose of 153 mg per dl, 8.5 mol/L. Two-step strategy. Step 1. Perform a 50-gram glucose challenge test irrespective of the last meal. If PG at 1 hour after the load is greater than or equal to 140 mg per dl, 7.8 mol/L, proceed to Step 2. Step 2. 100 g glucose OGTT is performed after overnight fasting. Cutoff values are fasting PG 95 or 105 mg per dl, 5.5/5.8 mol/L, 1 hour PG of 180 or 190 mg per dl, 10.0/10.6 mol/L, 2 hour PG of 155 or 165 mg per dl, 8.6/9.2 mol/L, or 3 hour PG of 140 or 145 mg per dl, 7.8/8.0 mol/L. GDM is diagnosed if 2 or more PG levels equal to or exceed these cutoffs. Treatment/management. For both T1DM and T2DM, the cornerstone of therapy is diet and exercise. A diet low in saturated fat, refined carbohydrates, high fructose corn syrup, and high in fiber and monounsaturated fats needs to be encouraged. Aerobic exercise for a duration of 90 to 150 minutes per week is also beneficial. The major target in T2DM patients, who are obese, is weight loss. If adequate glycemia cannot be achieved, metformin is the first-line therapy. Following metformin, many other therapies such as oral sulfonylureas, dipeptidyl peptidase 4, DPP-4, inhibitors. Glucagon-like peptide 1, GLPI, receptor agonists. Sodium glucose co-transporter 2, SGLT2, inhibitors, pioglitazone, especially if the patient has fatty liver disease, alpha-glucosidase inhibitors, and insulin, are available. Recent studies have shown that the SGLT2 inhibitor, empagliflozin, EMPA, and the GLP-1 receptor agonist, liraglutide, reduce significant cardiovascular, CV, events and mortality. Hence, in patients with CV disease, these drugs should be considered next. For patients with T1DM, a regime of basal bolus insulin is the mainstay of therapy. Also, insulin pump therapy is a reasonable choice. Since hypoglycemia portends increased mortality, preference should be given to therapies that do not induce hypoglycemia, for example, DPP-4 inhibitors, SGLT2 inhibitors, GLPI receptor agonists, and pioglitazone with metformin. The other advantages of SGLT2 inhibitors and GLPI receptor agonists are a reduction in body weight, blood pressure, BP, and albuminuria. To reduce microvascular complications in the majority, the goal HbA1c should be less than 7%. Also, the BP goal should be less than 130/85 mmHg with a preference for angiotensin-converting enzyme, ACE/angiotensin receptor blocker, ARB, therapy. Fundal exams should be undertaken as proposed by guidelines and urine albumin excretion at least twice a year. For the lipid panel, the goal should be an LDL-C less than 100 mg per dl if no atherosclerotic cardiovascular disease, ASCVD, or less than 70 mg per dl if ASCVD present. The drug of choice is a statin since these drugs reduce CV events and CV mortality. Consider adding ezetimibe and PCSK9 inhibitors for patients with ASCVD who are not at goal. Since the different complications and therapies have been detailed in other StatPearls review articles, we have outlined only the principles of therapy. Differential diagnosis. The list of differential diagnosis of diabetes mellitus consists of various conditions that would exhibit similar signs and symptoms. Drug-induced signs and symptoms due to corticosteroids, neuroleptics, pentamidine, etc. Genetic aberrations in beta cell function and insulin action. Metabolic syndrome, Syndrome X. Infection. Endocrinopathies such as acromegaly, Cushing disease, pheochromocytoma, hypothyroidism, etc. Complications of iron overload, hemochromatosis. Conditions affecting the exocrine part of the pancreas such as pancreatitis, cystic fibrosis, etc. Prognosis. DM is associated with increased atherosclerotic cardiovascular disease, ASCVD, and treating blood pressure, statin use, regular exercise, and smoking cessation are of great importance in ameliorating risk. The overall excess mortality in those with T2DM is around 15% higher but varies widely. The prevalence of vision-threatening diabetic retinopathy in the United States is about 4.4% among adults with diabetes, while it is 1% for end-stage renal disease. Today, with pharmacotherapy for hyperglycemia, as well as lowering LDL cholesterol and managing blood pressure with ACE/ARB therapy, with other antihypertensive medications and aspirin in secondary prevention, vascular complications can be managed adequately, resulting in a reduction in morbidity and mortality. Complications. Persistent hyperglycemia in uncontrolled diabetes mellitus can cause several complications, both acute and chronic. Diabetes mellitus is one of the leading causes of cardiovascular disease, CVD, blindness, kidney failure, and amputation of lower limbs. Acute complications include hypoglycemia, diabetic ketoacidosis, hyperglycemic hyperosmolar state, and hyperglycemic diabetic coma. Chronic microvascular complications are nephropathy, neuropathy, and retinopathy, whereas chronic macrovascular complications are coronary artery disease, CAD, peripheral artery disease, PAD, and cerebrovascular disease. It is estimated that every year 1.4 to 4.7% of middle-aged people with diabetes have a CVD event. Deterrence and patient education. Patients must be educated about the importance of blood glucose management to avoid complications associated with DM. Stress must be given on lifestyle management, including diet control and physical exercise. Self-monitoring of blood glucose is an important means for patients to take responsibility for their diabetes management. Regular estimation of glucose, glycated hemoglobin, and lipid levels is necessary. Healthcare professionals should educate patients about the symptoms of hypoglycemia, such as tachycardia, sweating, confusion, and required action, ingestion of 15 to 20 g of carbohydrate. Patients should be motivated to stop smoking. Emphasis is required on regular eye checkups and foot care.